So the hope is that the equation to have a very good information about prognosis after surgery is probably not going to be a single event, or it's not going to be a single marker. It's likely going to be a combination of markers, right? So the extent of pathologic response, whether or not you can still detect circulating tumor DNA, something called gamma interferon expression may be important as well. So there's a variety of markers that are being analyzed to see what is the best combination of markers to give us very good predictions of outcome. So we can better decide, okay, the prognosis is that after surgery, based on a variety of markers, it looks like the risk for this patient to developing distant disease is close to zero. So those patients probably don't need to have any more therapy, right? They probably just need the 2 or 3 cycles that they had up front, then they had surgery. And then there may be situations in which we may be able to biopsy the tumor bed in an accurate way to say, okay, all this tumor's dead. Maybe they don't even need to have surgery. Maybe they should just have there's 2 or 3 cycles of immunotherapy and then they're done, right? So that's the ultimate kind of goal, is to try to cure patients, up front, and maybe they don't need anything else except a couple, 2 or 3 cycles of immunotherapy. I mean, we're quite a ways from that, but that's like the holy grail, right? So here's a great example. So in colon cancer, about 10 to 15% of the patients have this mutation where there's something called mismatch repair deficient, or something called microsatellite instability high. So this group of patients has a 95% major pathologic response rate to combination immunotherapy. And only after 2 cycles of combination immunotherapy in this selected group of patients who have this marker have a major pathologic response rate of 95%, meaning that 95% of the patients have not recurred after surgery. So that's a perfect example of a predictive biomarker, right? So those are the kind of things that we need. Because if it turns out that, like for lung cancer, we used to think that lung cancer was like one disease. Well, based on certain tumor markers, lung cancer is about 10 different diseases, and we have agents. So these are kind of genetic abnormalities that are actually actionable, meaning that we have drugs that can target these mutations. And that's probably what's going to happen long term in all the solid tumors, because there's so much heterogeneity that if we identify the right biomarker, that could dictate what kind of therapy they're going to have and what type of response they're going to have. And really, the best way to do this biomarker discovery is using a neoadjuvant platform, actually.